Our speaker is going to be speaking on diabetic retinopathy screening in Nigeria. And our speaker for today is Professor Dennis George Ukanga. Professor Dennis George is a professor of ophthalmology. He is a medical retina specialist and public health ophthalmologist. He is also the head of medical retina services and clinical lead diabetic retinopathy screening and treatment services at the University of Calabar and the University of Calabar Teaching Hospital. His special interest is in retinal diseases, especially the prevention of avoidable loss from diabetic retinopathy, where he is very active in advocacy, human resource development, research, and setting up interventions both locally and nationally. Dr. Ukanga brings his public health mindset to medical retina, seeking to create equitable, sustainable interventions that facilitate universal access to care for the population. He graduated with a medical degree from the College of Medicine and Sciences, University of Calabar, after which he proceeded to work under the tutelage of legendary Dr. Dimma Faibasima at the Odadiki Eye Hospital on Odadiki Eye Foundation in Port Harcourt. He did his residency in ophthalmology at the University of Nigeria Teaching Hospital in Enugu. He is a fellow of the West African College of Surgeons, and he holds a master's degree in community eye health from the International Center for Eye Health London, which he completed with distinction in 1995. In 2006, Dr. Ukanga became the second international fellow accepted to the Medical Retina Training Fellowship of California Retina Consultants in Santa Barbara. He had the privilege of training under Dante J. Permisi, one of the pioneer researchers on the then novel treatment with anti-VEGF, between 2014 and 2015. He completed the Commonwealth Eye Health Consortium Medical Retina Fellowship at the Wolverhampton Eye Infirmary of the Royal Wolverhampton NHS Trust, United Kingdom. He is a resource person for several postgraduate colleges. He served as a volunteer for several charities, including the Eye Care Africa, Pro Health International, amongst others. He has been a consultant on several projects for state governments, especially in the area of development of state eye care plan, APOC program evaluation, and currently the FMOH, that's the diabetic retinopathy guideline development, amongst others. He has led and participated as investigator in several clinical research and has over 55 publications in leading peer-reviewed medical journal. He is a member of several professional groups and society. He is passionate about the advancement of eye health equity. I'd like to welcome Professor Ukanga to please take on his lecture. Thank you so much, sir.
Good morning. Thank you. I hope you are seeing my screen. I would like to express my special appreciation to Dr. Kunle Hassan and the Kunle Hassan Eye Foundation Academy for this invitation to speak in your distinguished lecture series. It was heartening to note that Dr. Kunle Hassan was part of the team that gave us the international classification for diabetic retinopathy. I work from the University of Calabar Teaching Hospital, which came out of the St. Margaret's Hospital, the oldest public general hospital in Nigeria. I have no financial disclosures to make. I like the picture there. That's me going to run my clinic in the early first quarter of 2020 at the peak of the COVID-19, when we had to wear our N95 mask and even wear face shields because we were dealing with a major epidemic. Yet, diabetes is the fastest growing global public health emergency of the 21st century. Its chronic lifelong complications, morbidity, mortality, and increasing healthcare expenditure makes it the #1 public health problem for this century. Its multi-systemic nature ensures that no organ or tissue is spared, Complications of diabetes are becoming the most significant cause of ocular morbidity and avoidable blindness. Diabetic retinopathy, a specific microvascular complication of diabetes, affects 1 in 3 persons living with diabetes. It's the leading cause of preventable vision loss in the working adult population. Therefore, it carries with it profound socioeconomic significance. It was in recognition of these facts that the 42nd World Health Assembly in 1989 issued a global call for action on the prevention of and control of not just diabetes, but also its complications. 4 regional diabetes declarations followed, which paved way for national diabetes programs in several countries, beginning with the St. Vincent Declaration of Europe, the Declaration of the Americas, the Western Pacific Declaration on Diabetes, and the Declaration and Diabetes Strategy for Sub-Saharan Africa. These declarations recognize the contribution of diabetes to blindness and vision loss. They also recommended a reduction of at least 1/3 or more of new blindness from diabetes as one of several targets in the 5-year period. They also recommended a national strategy of screening for diabetic retinopathy. 17 years after the Declaration for Diabetes Strategy for Sub-Saharan Africa, we are still about to start a national program in Nigeria. More than 500 million people are living with diabetes. 3/4 of them live in low and medium income countries, so the poorest are the hardest hit. Half of the 90% that are undiagnosed, half of these diabetes are undiagnosed, and 90% of the undiagnosed cases live in low and medium income countries. Africa stands at the center of this global epidemic. The number is expected to increase from about 500 million in 2021 to 780, close to 800 million in 2045. And 113% increase is expected in Africa, while Europe will have about 13% increase. The global prevalence of diabetes is put at 10.8% in urban areas and about 7.2% for rural areas. Most of the diabetes burden comes from type 2 diabetes. Even with the global population expected to increase within this same period, 2021 to 2045 by 20%, diabetes, the prevalence of diabetes is expected to increase by close to 50%. Diabetes imposes a substantial economic burden on countries, health systems, and families of people who are living with diabetes. By 2021, it was estimated that 966 billion was expenditure on diabetes and its complications alone, and this is expected to increase astronomically. Nigeria bears a significant burden of blindness, of diabetes, and the complications of diabetes. The meta-analysis by Andrew Uloko et al. In 2018 shows large variation in the various geopolitical zones of Nigeria, with the South-South carrying the heaviest burden. Several studies have been done in Nigeria on prevalence of blindness, but the landmark study by Nwosu et al. In 2020 in an eye clinic population showed a prevalence of diabetic retinopathy of 33%. Our study done in Calabar, Agueye et al. Showed a prevalence in the diabetes clinic of 26%. The study by Chiari et al. In the community reported a prevalence of diabetic retinopathy among people living with diabetes as high as 20.5%. Aziz et al. In a systematic review and meta-analysis of prevalences in Nigeria had a prevalence of 21.3% for diabetic retinopathy. So that shows that diabetes is quite a significant problem in Nigeria and in our various geopolitical zones. Diabetic retinopathy meets all the requirements for a screening program, working with the Wilson and Junga principles. The condition is an important public health problem. There is an accepted treatment for patients with recognized disease. Facilities for diagnosis and treatment are available. There is a recognizable asymptomatic or early symptomatic phase. There is a suitable test for examination and an acceptable sensitivity and specificity for that test. The screening test is acceptable to the population. The natural history of diabetes and diabetic retinopathy is well understood, including development from latent to declared disease. And there is an agreed policy on treatment of patients. Screening and early treatment is cost-effective intervention and has economic benefits. So, Wilson and Junga principle, diabetic retinopathy ticks all the boxes. It is a significant part of the workload of retinal specialists in Nigeria. Early detection of asymptomatic diabetic retinopathy is crucial to timely initiation of treatment and prevention of vision loss. We have effective treatment that will prevent vision loss, the beneficial effects of laser and the use of anti-VEGF injections, intravitreal injections are well recognized. Diabetic retinopathy is associated with poorer quality of life and reduced level of physical, emotional, and social well-being. People living with diabetic retinopathy utilize health resources more than the rest of the population. Visual impairment from diabetic retinopathy is known to negatively affect other health outcomes in patients with diabetes. The screening is cost-effective intervention with economic benefits. Many people do not know that diabetic retinopathy screening is already mandated as part of the minimum package of care for patients with diabetes living in Nigeria. The National Guideline on Prevention and Control Management of Diabetes in Nigeria has a chapter on diabetic retinopathy, and it mandates screening at least once every 2 years. The journey of diabetic retinopathy screening in Nigeria began many, many years ago. Pre-2015, several opportunistic periodic screening programs have been done by several centers in Nigeria, and most of it was linked to World Diabetes Day, World Site Day, and other activities, and a lot of it going on in eye clinics. Between 2015 and 2017, two centers in Nigeria, the University of Calabar Teaching Hospital and the Lagos University Teaching Hospital, started systematic screening programs along with the ongoing opportunistic screenings that are going on in other facilities. But these were independent programs running separately. Towards the end of 2017, the two centers came together and developed uniform screening protocols, uniform guidelines on screening, and that has been coordinated by the Diabetic Retinopathy Network. But in 2023, we are expecting that this will be another watershed moment as the federal government of Nigeria is leading the effort to develop uniform guidelines and for screening and coordinate screening activities for diabetic retinopathy in the country. We tried to establish the status of screening for diabetic retinopathy in Nigeria. So I'm reporting a descriptive cross-sectional study aimed at mapping DR services in Nigeria, which was conducted between May and June 2022. Participants who consented were identified from mainly ophthalmologists and optometrists who were involved in DR screening. Study participants were reassured that the study will not be presented at individual hospital levels. An online questionnaire was distributed and shared through the Vitreoretinal Society of Nigeria, the Public Health Ophthalmology Group, and the Nigerian Optometric Association. Ethical approval was obtained from the Health Research Ethics Committee of the University of Calabar Teaching Hospital. All analysis and statistical tests were conducted using the SPSS software. Simple descriptive statistics were used to generate frequencies, percentages, and proportions. What we found is that about 51.1% of respondents identified themselves as optometrists. 48.9% of respondents identified themselves as ophthalmologists. Most respondents practiced in the public health sector, about 64% in the public health sector. A total of 83% of respondents were based in urban areas. From the response we got, there was some screening activity for diabetic retinopathy ongoing in all the geopolitical zones of Nigeria, although for obvious reasons, the northeast of Nigeria was the least represented, probably because of the crisis in that part of Nigeria at the time. Most of the screening were opportunistic screening. Nearly 70% of the screening was opportunistic. There was systematic screening ongoing in the south of Nigeria. Most of the screening locations were in urban areas. Very little was going on in rural areas. Most of the screening took place in eye clinics. 75.5% of the screening was done in eye clinics. There were very few places where diabetes center screening was ongoing. Medical and other clinics also had screening services in mainly the South and the Southeast. Screening technique, we found that a lot of reliance on the direct ophthalmoscope and the use of slit lamp and indirect lenses was happening. Some people also used indirect ophthalmoscopy. Some used the fundus camera, and there were many people who used handheld devices like mobile phones and handheld devices for their screening. Another thing that we found during the study was there was no uniformity in screening protocol and across the country. Grading and referral criteria was also different across the country. DR screening is conducted mostly in fixed locations in eye clinic based in urban areas in Nigeria. This will not allow for an equitable service. The majority of screening activity are opportunistic instead of a systematic model. Ophthalmologists were involved in DR screening and grading. Direct and indirect ophthalmoscopy was employed as the common techniques in use. Screening protocol across the country and across centers were not uniform. There was no national or regional population-based equitable screening ongoing in the country at the time of the survey. Diabetic retinopathy screening activities of varied quality using different grading criteria and referral threshold ongoing. This highlighted the urgent need for standardization, for adoption of uniform standards, photographic fields, DR grading, and referral cutoffs. Although all zones in Nigeria had some form of eye check for people with diabetes, they are not adequately resourced and systematically organized into a DR screening pathway. While these opportunistic screenings are easier to establish and have variable quality outcome, they lack the capacity for population screening needed to achieve blindness prevention from diabetic retinopathy. A systematic, quality-assured, integrated service will promote early diagnosis, eliminate the gaps in quality, and respond to issues of equity in care system. That was our recommendation. A system where ophthalmologists do screening and grading is not cost-effective use of specialist manpower. Indeed, if we look at the population of Nigerians with diabetes and we look at the population of Nigerians ophthalmologists, if every ophthalmologist was examining and screening 25 patients with diabetes every day, it would take 2 years for all Nigerian ophthalmologists working only on diabetic retinopathy alone to screen all patients with diabetes in Nigeria. So it's really not a practical intervention for diabetic retinopathy. Training of screeners and graders Deployment of SEM to handle screening and grading will be a more practical way to deal with the problems of diabetic retinopathy in Nigeria. Establishment of grading portals and hubs will help enhance equity so that people can screen in various locations and send in the pictures through the portal and have it graded, and a larger population can be reached. Artificial intelligence will also help achieve faster grading, better, good outcome, and timely referrals for patients with diabetic retinopathy. So we recommended that although digital retinal photography is still considered the most effective DR screening technique, many countries, and indeed Nigeria, lack the capacity to deploy it completely across our population. But this lack in capacity should
Professor Dennis, you are muted, sir. Please check your microphone. We can't hear you. You are still muted, sir. We can't hear you.
Okay, can you hear me now?
Yes.
Okay. I don't know how long I've been muted for.
It was the slide before this.
Okay, was it at this point?
You were at this. Yes, I think it was
from
this
here.
slide.
Okay.
You are muted right here.
Okay. So a systematic, quality assured, integrated screening service will promote early diagnosis, eliminate gaps in quality, and respond to issues of equity of care systems. We said that a system where ophthalmologists were doing DR screening and grading was not a cost-effective use of specialist manpower. If about the 2 million people with diabetes, the 6 million people with diabetes in Nigeria, if all of them were being examined and screened by the ophthalmologist available in Nigeria, it's going to take us 2 years. If we see 25 patients with diabetes to screen every day through the year, it will take us ophthalmologists 2 years to screen for diabetic retinopathy. So it's important to have other people trained as screeners and graders and encouraged to do the screening and the grading. If we deploy grading portals and hubs, then it should be possible to deal with the equity issues where wherever you are able to do the photographs, it can be graded from a central location. We should also consider the place of artificial intelligence to achieve quicker grading and early referrals. Digital retinal photography is considered the most effective DR screening technique. Many countries, including Nigeria, lack this capacity. But the lack of this capacity should not stop the commencement of DR screening. Incremental use of digital retinal photography and OCT should be encouraged as resources become more available. Many low and middle income countries, including Nigeria, lack adequate laser capacity. A stepwise improvement strategy with a progressive increase in laser capacity and training is advocated. I think my opinion is that the availability of one laser should be enough for the commencement of screening in a city. Attention to the development of equipment maintenance capacity is very important. The Diabetes Register is the framework for a systematic screening service, especially in a system like ours where we have a fragmented health system across family doctors, private practitioners, endocrinologists, ophthalmologists, hospital care, all working in different silos. That means that everyone may not get into a screening pathway. So to break that pathway, we really need to have citywide diabetes registers from which we can draw patients for screening. A focus on DR screening pathway and quality using an integrated e-health information system can create a high-quality, equitable screening service where everyone has a high chance of having access to such screening service. A stepwise progression and transitioning to systematic screening based on availability of personnel and resources is recommended. There is need to put in place an appropriate governance, information system, and financing model to enhance this. I'd like to share some of our insights from the Calabar DR screening. One of the early things that we did with the Calabar DR screening was to define the area of coverage. We defined the area of coverage. The area of coverage was Calabar, and we brought all the stakeholders together, private practitioners, public health physicians, endocrinologists, heads of departments of internal medicine, representatives of Patients Diabetes Association of Nigeria together to work together and develop an integrated service, a service we can integrate into the diabetes care system. So these are some of the pictures. Another thing that I would like to encourage, the Calabar Diabetic Retinopathy Screening and Treatment Service was developed with the LINKS program. So our partners from the Royal Wolverhampton NHS Trust were part of it. So you can see the pictures from our meeting, signing of MOU between the University of Calabar, the University of Calabar Teaching Hospital, the Royal Wolverhampton NHS, so that while that ensured that the training that was necessary and every part of that service was developed together. The tools are important. We get all the tools that we need, get the protocols right, and we can then get to work. Building capacity for screening, capacity for grading, capacity for treatment, capacity for equipment maintenance is key in the screening program. A sustainability plan is also important. Governance, audit, monitoring and evaluation and learning and improving is so important for the service. We use every opportunity to train and retrain our people. So the graders are continuously being trained the screeners and the graders are continuously being trained. Every technician in the department, we try to pass them through training on how to take good retinal photographs and make grading possible. Because we cover an area and we have an outreach strategy, apart from screening in our base center, we also have mobile applications, attachments to mobile phone that we use for screening outside of our center. I'm happy to report that the Nigerian National Screening Guideline is at advanced stage of its development. We are grateful to the leadership of the National Eye Health Program in the Federal Ministry of Health, led by Dr. Oteri, our own Dr. Oteri. In 2019, a National Diabetic Retinopathy Stakeholders Meeting was held in Calabar on the sidelines of the Ophthalmology Society meeting. The need for a national guideline for standardized quality assured screening was understood. And in 2022, the Federal Ministry of Health began the process of guideline development by appointing consultants, a technical working group, and a multidisciplinary group of stakeholders met in January of 2023. And right now, the guideline document is undergoing ministerial review before presentation to the National Council on Health. Such a guideline is necessary for clinical governance, for audit, for monitoring and evaluation to be seamless part of the process. The Nigerian National Guideline for Screening and Management of Diabetic Retinopathy will serve as a roadmap towards the reduction of visual impairment and avoidable blindness. It will facilitate the achievement of universal health coverage for people living with diabetes and the attainment of relevant sustainable development goals in Nigeria. It will serve to mitigate the social and economic burden of avoidable vision loss from diabetic retinopathy for individuals, communities, and the whole country. An integrated diabetic retinopathy service will be integrated into primary care levels, secondary care levels, and tertiary care levels. The guideline will help and facilitate standardization and quality of care, screening and referral guidelines, referral networks, leadership, governance, financing and sustainability, and research. In conclusion, all hands are needed on deck as improving health for people with diabetes is known to reduce mortality, to improve other health-related outcomes, improve quality of life, increase productivity, advance several sustainable development goals, including poverty reduction, zero hunger, quality education, gender and equity, and decent work. By screening for diabetic retinopathy, we will be killing 20 birds with just one stone. I I'd like to acknowledge the support that the Calabar Diabetic Retinopathy Screening and Treatment Program has had from the Vice Chancellor of the University of Calabar, the Chief Medical Director, the Lions UCTH Diabetes Center staff and patients, Professor Kon Essien Ofemenang and the endocrinology team of our hospital, Mr. Nick Price and the team at the Royal Wolverhampton NHS Trust, Professor Yit Yang Ajay Bhatnagar, Professor Nero Nurendran, Marcia Zondervan of Vision 2020 Links in CHEFA London, Miss Adele Pinnock, Dr. Kova, and the team at Diabetic Retinopathy Network, the team from the Commonwealth Eye Health Consortium, and the great team and partners of our program from the Lagos University Teaching Hospital, led by Professor Shade Akinshola, Dr. Tunji Adenekon, and the rest of our colleagues. We thank you, and it's been nice working with them. Thank you, Kunle Hassan Eye Foundation Academy, for inviting me to make this presentation.
Thank you very much, sir. We really appreciate you giving us your time to take on this interesting lecture. It's time for our Q&A session. If anyone have any questions, please feel free to type it in the chat box or raise your hand, and we'll call on you to unmute your mic and ask your questions. Any questions, comments? Please ask your questions. I'm not so sure. I'm so sorry if I don't address you right. If you're Dr. Basil Morgan, you have your hand up. Please unmute your mic and ask your question. Thank you.
I enjoyed the lecture. Thanks to Professor Makanga. One of the suggestions I would make is that try and put a remote screening device read by a central center in areas where people traffic. For instance, the ladies get their hair done pretty often and put it in their area, put in where the hair is being done. Secondly, optometrists could put them in their satellite offices and we'd coordinate with one reading center. The AI technology could rapidly grade and get the information back to the referring optometrist. I really suggest it's easier and manpower to put the remote screening devices in the highly trafficked area where the population will be easier to get to.
Thank you, Professor Morgan. We are still in the early days of the screening program. So we are moving and we will take that suggestion up. We are developing the mobile apps. Right now, we are doing studies with what we call the Paxoscope, training people to use Paxoscope with a mobile phone to take retinal pictures. And once we are able to establish its effectiveness, then we will have a tool that we can put in several places where diabetes people have high traffic. We are looking at introducing within the Calabar, because right now we are just, our screening program is limited to our city. We are working with private practitioners in the city and in several areas where we have any place where they make a diagnosis of diabetes, where patients are treated with diabetes, we want to get screening services out there to them. And we also encourage them to refer patients so that we have a comprehensive list. We expect that there are 10,000 people with diabetes in Calabar. Right now, we have about 3,800 on our diabetes register. That's close to 40%. And we are still building the diabetes register for the city.
Okay, I have Dr. Maria. Your hand is up. Please unmute your mic and ask your question, please.
Thank you, Francis. Good morning, everybody. Thank you, Professor Nkanga, for that very lucid presentation. My question are maybe 2 or 3. The first one is diabetic retinopathy and maybe diabetes mellitus has been found to be more common in the south of Nigeria. Now, what could be the possible reasons? Have they been discovered why it is more predominant in that part of the country? Could it be because of the screening that is going on in Calabar or other reasons? And are there educational programs to enlighten them to possibly, maybe if it is due to nutrition or other lifestyle, are there educational programs to the people to help them change for better health? Then my final question is it possible to spread this screening that is ongoing in University of Calabar Teaching Hospital, which is very, very good? Is it possible to spread it to these other parts of the south and maybe the whole country? Thank you.
Thank you. Let me begin with the second part, spreading screening. The Federal Ministry of Health has taken up leadership. And from the pace that they are going, we are confident that screening services will gradually spread across the country. We are confident in the leadership of the National Eye Health Program. The Vitro-Retina Society of Nigeria is also making a lot of effort on the work of diabetes retinopathy. And with the Vitro-Retinal Society making effort, I think what is needed is to work together with the Public Health Ophthalmology Group. If the VR Society and the Public Health Ophthalmology Group works together under the current leadership from Federal Ministry of Health, I think that a great work will be ongoing. I have seen the hand of Dr. Chimeze Obingbam, and I want to acknowledge the great work that he is doing in the field of diabetic retinopathy. I think we will hear from him directly as a person. We have had a lot of support from Dr. Kiari, who is also in this meeting. And I'm happy that Professor Basil Morgan is also joining us because he has done a lot of work in eye care, not necessarily diabetic retinopathy, but he has also been part of my training. Working with him around places on charity work has been a great privilege for me. Thank you, Professor Morgan. Oh, the second part of the question was on the high prevalence. I think this is a meta-analysis of prevalence studies that have been done across many years. I think the entire prevalence studies done from the year 2000 by several members of our society, and they found this. I'm sure the NCD group at the Federal Ministry of Health will do what they need to do. We as practitioners, we are also doing enlightenment. We are doing a lot of enlightenment on retinopathy. I think the EMSOM, the endocrinologists, are doing some work on diabetes itself.
Thank you very much.
Professor.
Please go ahead, Dr. Maria. Sorry about it.
you, Professor Nkanga. I appreciate your presentation. Keep up the good job. Thank you.
Okay, I have Dr. Golding Chimeze. Your hand is up. Please go ahead and unmute your mic and speak, sir.
Okay, good morning, everyone. My name is Dr. Golding Chimeze. I work with Federal Ministry of Health. And thank you, Prof, for the elucidating lecture. I just wanted to add a little, maybe perhaps you have been miserly with some of the things you know. We've gone a long way in this project as a country, and we support from everyone in the international and locally. Prof has been the lead, and he's done a very good job. Like he said, we are doing the ministerial review of the document at present, as well as costing the document. So those parts we speak to. And in addition to that, we have a project of piloting the implementation in several states, about 8 states in the country. And that spreads around the 6 geopolitical zones. And so the aim is to help everybody in Nigeria to have access to diabetic retinopathy, at least with a center that has a full complement of the endocrinologist, the vitreoretinal surgeon, the medical retina specialist, as well as a physician, family physician that can also help where there is no endocrinology. So there are centers that has been earmarked for this, for the pilot, that which is the next phase of the work when we finish the review. So the process is ongoing and will continue to be, because the whole aim is to get it across the whole federation. The primary health care agency, the National Primary Health Care Agency, is also involved in the work. So the aim is to ensure that people who are from the primary health care centers who are diabetic are already recruited into the diabetic register from the beginning, so that referrals won't have to wait when people who are already blind from DR or people who have stage 4 diabetic retinopathy could come into the system. No, we want a situation where we start with the annual screening process for each diabetic patient is supposed to have. And we know that the incidence of diabetes is already on the increase considering our lifestyle. So that's why we are going with that. We also had collaborated with the Endocrinologists Society of Nigeria, and they are also working on enlightening their members to be part of this process, because it's diabetic retinopathy, yes, for the ophthalmologists, but the bigger picture is that it is the whole system, and we can't do that without the endocrinologists too. So it's a multi-sectoral and a multifactorial collaboration we are doing, and for mine, we're also working with the, like Prof said, we have the NCDs. There is currently ongoing the STEP survey that is going on in the ministry. And so that will also throw more light on the prevalence of diabetes all over the country. So these are all avenues that is being explored. It's a journey that is ongoing, and it starts with a step. And by the time we're through, I'm sure we'll be better off for it. So we are making progress, and very soon we'll arrive at the destination point. Thank you.
Thank you, Dr. Golding. Thank you. I have Dr. Victoria Olatunji. Please unmute your mic and ask your question.
Oh, thank you. Thank you very much, Professor Kanga, for the very lucid and revealing presentation. Well, I know that in some countries where DR screening is really effective, they use national DM register. So I just want to ask that, are we also planning to have a national DM register, or is it going to be state by state? For example, in Calabar, how you've been able to successfully organize this screening service, are you using a DM register probably meant for the state? Thank you.
Thank you, Doctor. Let me also acknowledge the presence with us in this meeting of Miss Mary Brenda. Miss Mary Brenda is working with us in Calabar, and she has developed an AI app that will help in the grading of diabetic retinopathy. Her app is yet to be tested in a big way, but we acknowledge her contribution. Yes, a DM register is very important, crucial to a systematic screening program. Unfortunately, like in the UK, where they have a national health service, where immediately the diagnosis of diabetes is made, a person is entered into a national register. We don't have that kind of health service in Nigeria. We have a fragmented health service where sometimes private practitioners will hold on to their patients and may not send them in. I think when we have a national policy, which is what Dr. Chimeze Obingbam told us about, then it will be mandated that once you make the diagnosis, you will refer the patient into a screening program, and that register will be part of that national guideline which we are expected. At the present time, for us in Calabar, it's been a lot of hard work. We call stakeholders meeting, what we call collaboration meeting, and colleagues in private practice everywhere to refer their patients and to help us to get this register. So we have a DM register that we are building one brick at a time. And we are happy that we have gone probably where we are close to 50%, because, you know, although I said there will be 10,000 based on a prevalence study in Calabar of 7% for diabetes and a population of 370,000 in our city, we expect 10,000 people with diabetes. But in our part of the world, only 50% of people with diabetes have had a diagnosis. So we are thinking that we probably have 5,000 people in our city who have had the diagnosis, and we are close to 4,000 on our register. We are still at 3,800. So it will be easier with the national policy after it has been launched.
Thank you, everyone. We'll take one more question and I'll read the comments from the chat section so that we can wrap up. Dr. Mary Brenda, please, can you unmute your mic and ask your question, please?
Hi, thank you. Thank you, Prof, for your enlightening presentation. You mentioned the imminence of a central portal where fundus images could be uploaded and graders could then provide diagnosis on these images. And I would like to know how far along is the development of this portal?
It's what is being suggested. You have heard Dr. Chimeze Obingbam, who has spoken from the Federal Ministry of Health. You know, health in Nigeria is both at the federal level and sub-national levels. So I think they are doing an excellent work coordinating it. These are our suggestion that a portal and a grading hub will make services more equitable. So whether there is a grader in your city or not, because right now where we are, I know of only 6 graders in Nigeria who have been trained in grading. So it's going to be a long walk to freedom. We will need to begin to train screeners, train graders, or use a hub with artificial intelligence to make this more realistic. So how far we have gone will lie in the answer that Dr. Chimeze had given to us. We are just beginning the journey.
Okay, thank you.
Thank you so much. Sorry.
Can I talk?
Sorry. Yes,
Okay.
please go ahead.
Okay, so I wanted to add a little. There is for the information before the last one, there is a national diabetic register that is going to come on. Part of our national indicators for eye health in Nigeria, which will be hosted on the DHIS2, which is the District Health Information System 2, is diabetic retinopathy patients that have gotten access to laser. And the essence of that is to know the treatment access to diabetic retinopathy all over the country. But at each center that will have screening, even from the primary healthcare center at the primary level of care, we expect that the diabetic register will be there, because the recruitment will start from that level, and information gotten from that level will also be transmitted to the national portal, which is housed. So by the time we finish the process, every center doing diabetic screening will have a diabetic register, at least at the government side. And currently, we are also planning training people on this, and that will also help the uptake of diabetic retinopathy screening, as the case may be. It's a long walk to freedom, like Prof said, but I think we are making a lot of progress, and with the cooperation of everyone, we are getting there. The last person, I think he talked about the diabetes. Sorry, I tried. Okay, I'll go ahead. I think later I'll talk again, if possible.
Okay, we're bringing the session to an end so that we try to keep to time for others as well. I'll take one more comment and we'll wrap up. So the comment is from Professor Fatima Kiari. She said there is a diabetes education master's course run by the University of Abuja targeted at diabetes care providers, patients, as well as their carers. She said it's a new program and it's about to start this year. Thank you so much, Dr. Kiari, for that information. And she also adds and saying, thank you, Professor Kanga, for a brilliant and enlightening presentation. So we would like to bring this session to an end. This Retina series, anchored by the Kunle Hassan Eye Foundation Academy, takes place once every month, particularly the first Wednesday of every month. So there'll be another edition coming up in June, and which precisely June 7th, we'll be circulating that. We also have a YouTube channel for the Kunle Hassan Eye Foundation Academy. If you missed our previous lectures, and you want to check up on all our other series, you can catch up on those lectures. So once again, I'd like to thank Professor Dennis Okanga for taking out the time to take us on this interesting topic. Thank you very much, sir. And thank you for everyone for giving us your time and taking time to join this lecture. Thank you very much. If you have other questions, you can always email, and maybe we can start off with those questions sometime before the next lecture. Thank you so much. Thank you.